for your knowledge, but surgeons can be interested in blood management as well. It's a whole group. I'm the only surgeon of that group. The rest are hematologists. And it's a big collaboration we had. So this blood. Well, we use it a lot, I think, in all the different countries. Even during a breakfast I had, I approached several surgeons and asked them what they think about when do you give blood. Well, I'm a surgeon. I like to put in yeast and do RSA a lot. That's my main topic. In those days it was less gray. The trigger for me to start this research was actually a Trali accident. I don't know if a lot of surgeons of you heard about the Trali. Who heard about it? Trali? Okay. That's two of the whole audience. Well, I didn't know about it. And Trali can have a tremendous effect on the patient. The patient can die. In the beginning, you think you don't see anything, but after a while, the patient might die. When you look at total knees and total hips, we have a certain amount of blood loss, and then we tend to give blood. In the Netherlands, you say, hey, blood loss. They think, hey, give them 2, 3, 4, whatever units of blood, of red-packed cells. But when you look at Van Vakkas, a world-renowned hematologist who works in UCLA, this recent review he wrote in April, that's important here. Blood still kills. Even in 2010, blood is very dangerous to use. I think most surgeons, at least I, was not aware of the fact until about 10 years ago. These things might occur. So Trali is a transfusion-related acute lung injury, and people die from it. The incidence it's not very clear how often it happens. And of course, you have the hemolytic transfusion reactions, you have the sepsis, and all those things can happen to patients. We think it's very seldom, but it happens. When you look at the FDA, these are data from a paper from Van Vakkas in Blood in 2009. You see the reported fatalities, people getting dead from blood, is still pretty high. And of course, this will be an under-report of all the accidents which are really happening in the US. But also for us as orthopedic surgeons, we know when we have more units of blood, there will be a higher risk of infection. Whether it will be to the difficult case you had more difficult case, your surgery will be prolonged, or due to the fact that you have to give blood back, and usually the white cells might induce some extra immunological response with an increased rate of infection. So blood is not always like 2, 3, 4 units, but we should use a restrictive transfusion trigger, which was implemented in the Netherlands about 10 years ago. That means actually that you give less blood when you have a young, healthy patient, and when the patient has in a high-risk group, like ASA 3, 4, you give more, and it also depends on the amount of anemia you have. So now to have the Pavlov reaction, it's 10 grams per deciliter, you have to get 2 units. No, when it's healthy, you can wait till it drops more. Is there evidence? Yes, there's evidence. From our group, which was published in Fox Sanguinis, 2009, and several other groups, there's no effect for the patients on outcome. However, the patients who had the more liberal policy, they had more infections. Is there an effect on mobilization? No, there's not. This is now in ePubmed. It's also published this year, also by our group, and we did also in this randomized trial. We looked at scores, anemia scores, fatigue scores. At least on these scores, we couldn't prove any effect. So it seems to be safe to go lower. How about the other modalities to save blood? Is there evidence? When we look at the erythropoietin, that's a big story from Ferris and Weber in 2005, and they claim that they have 50 to 75% less blood use when they use erythropoietin in a certain group, between 10 and 13 grams per deciliter. Looking at drainage reinfusion systems, is recently, again, a Cochrane, the second Cochrane, and it was not really conclusive, at level C, because they're mainly not well randomized trials. And that's the end. It says it is in the difficulty of all the studies within the Cochrane is that the concealment of allocation was only mentioned, I think, in one study. That already means there's a lot of bias can be involved. So that means we need more research. And all those modalities need the washed blood, the unwashed blood, the erythropoietin, but also use of a restrictive blood transfusion trigger. That's very important. So all those different modalities were used to design a new study. There was a study design. It's quite complex, you can say. And that's the reason why we couldn't think about ourselves. We went to the statistical department, and in the end we had a 9-arm study, and we had to have at least 2,500 inclusions with a 90% power. It's only, and that finished a year ago, the study. We had, and we want to have at least a reduction in the uses of the packed cells of at least 75%, based on the studies of Ferris and Weber. And we wanted to have at least a 30% reduction in autologous reinfusion drainage. When they were used, you had less uses of blood. These were the prerequisites, the zero hypothesis. Now you get a very complex thing. Well, it's too complex for us. I make it more simple. Just basically, it says that when you are in the group for anemia, you are randomized to either EPO or no EPO. And then you get all the different modalities like cell saver, intraoperatively, the post-operative drainage reinfusion system, and also the control groups. So we had two control groups who didn't have EPO or had EPO without all the different systems. You can imagine it's a rather complex statistical trial. Well, the results I would like to share with you. These are just, the article will be sent in to the New England Journal next week. So these are, you can read it hopefully in the New England Journal in a few months. Well, we could evaluate these amount of patients. I'm only showing you the as treated patients, not the intention to treat, because that would be too complex. I only have 10 minutes, so it's much too short. What happens? Well, the figures, more females, more knees and hips, I mean, the things you know. This is very important here. What you see here, of the group we had, of the more than 2,000 patients, only 28% were eligible to having EPO. Of course, the mean preoperative HB, of course, is very important in this. Another interesting thing is that with the usage of a restrictive transfusion trigger, that was our policy, which was implemented already in hospitals 10 years ago, where only 12% of patients needed a transfusion. Of course, when you are in the lower, in more anemic HB groups, of course, you have more. The interesting thing is also, due to the fact we had this restrictive trigger, the mean usage was very low, units of blood. Here's some analysis, a lot of figures. The most important thing is, this is not really the odds ratios. You can see when one is included, that means that's not a real effect. So that might be an effect, but there seems to be a tendency there is that they use less transfusion, but not really a lot. So 6.6% with the autologous reinfusion versus 9% who didn't have this drainage system, intraoperative plus postoperative. This, however, is very important here. That's then, of course, we can pull the data of the EPO system. You see with EPO, that tend to be that people use less. The figure of this here, the units, is not statistical difference. However, you can look at the figures, there seems to be a difference. So don't believe all of those p-values. P-values are important, but also look at the mean values, of course. However, when you look at the odds ratio, it shows that people tend to be less transfused when they had EPO, about 67%. Conclusions. You can see that by using EPO, there's a lower percentage of patients being transfused. We also have a cost-effective analysis within that study. I can't show the data because they are being worked out. In the Netherlands, it costs about 2,000 euros, 40,000 units. And we start usually 3 weeks before surgery with the dosage. So you get 4 doses of 10,000 units. And that's 2,000 euros per patient extra, which have to be accounted for as well. For autologous blood reinfusion system, there was no effect in the groups when they had EPO. However, when they have the more higher HB groups, the ones who had an HB of more than 13 grams per deciliter, they might have an effect, 6.6% blood transfusions versus 9% when they didn't have a reinfusion. But the most interesting thing from the study is that only 12% needed a transfusion after total hip and total knee. And the reason is because we use this restrictive trigger. That's the most important effect we found, actually. So in the end, I think the major conclusion from the study, which can be read in a few weeks, months, is that use your brain to prevent patients from getting more blood than is necessary. And it is possible. Patients are not dying from it. These were the participating in hospitals, and it was possible by a grant from the Dutch government. Thank you.